First of all, thanks very much, Owen, for joining us today. Can you give us an introduction of yourself and your background?
I suppose I'm a hospital pharmacist by trade, working in University Hospital Waterford, which is a cancer centre located in the southeast of Ireland. And I've been there for about 10 years now. I've grown into a specialism of cancer services. I initially focus on the aseptic production of systemic anti-cancer treatments. But now we've become a bit more patient-centred and focused, and have become the Chief 2 Clinical Cancer Services Pharmacist. And then personally, I'm a father of one, Oisín, with my lovely wife, Ciara, and we're living happily about an hour north of Waterford in Kilcullen in County Kildare.
Oh, super.
Yes.
And can you share your journey and what led you to become a pharmacist?
I suppose that story is not particularly groundbreaking in the fact that I've probably followed the same route as many who joined the profession. I had a passion in school for the sciences, particularly biology and chemistry. And I suppose those always kind of marry up with a role in healthcare. For a time, I suppose I entertained the idea of becoming a forensic scientist, fueled by an obsession of CSI there and a thrill of solving those mysteries, you know. I suppose during our secondary school, we have a 2-week work experience placement, and I did one in a community pharmacy. And I suppose it was there that I discovered the love of, I suppose, patient care and I suppose that meticulous attention to detail that pharmacists are ultimately always have that kind of skill set, and it's something that I was immediately drawn to. I suppose just that sense of responsibility that you get with ensuring the well-being of others. Yeah.
Brilliant. What led you to specialize in cancer care?
So again, this is a story of kind of falling into a role rather than any kind of life event that is directed into me and down that route. I know you've had others on the podcast that may have had, family members affected by cancer, and I didn't get driven into it by some altruistic reason or anything. I suppose I specialized initially due to a maternity leave. So I was drafted in and taken off the bench and brought into cancer services. But I suppose I advanced that specialism just for the love of the specialism of cancer care. That the progress and the developments in the area are constantly evolving. We're dealing with clinical trials, compassionate access programs, and new licensed drugs every month of the year. And I suppose on top of that, the research that has been done on the ground level in cancer teams like across the country, you'll see it no matter what hospital you go to. It kind of cultivates an atmosphere of progression and self-improvement for yourself and your team. You're constantly expected to be up to date on the most gold standard aspects of cancer care in terms of not only the diagnosis and cancer treatments themselves, but also like the supportive care elements, treating hematological or oncological emergencies. And like I suppose as well, like that's the intellectual challenge and stimulation that's there. But you also kind of get a profound satisfaction from being part of a team as well. I've always found that the cancer team of oncologists, hematologists, nurses, pharmacists, physios, OTs, we really work together as a team, and it's very paramount that that team is dedicated to making a real difference in the lives of cancer patients and trying to make sure that that journey, that cancer journey that those patients are going on, is made as easy or as I suppose very rewarding to see, I suppose, the work that's put in by that team. I suppose to answer the question, it's an area that just keeps evolving and progressing at a challenging rate, and it's just a very rewarding specialism to be in.
Excellent.
Okay. Yeah. And as an oncology pharmacist, how do you see digital health transformation impacting cancer care today?
Yeah, good question. I suppose, first of all, right, I'll break down that term oncology pharmacist, right? So as I alluded to before there, I've had experience as both a pharmacist involved in the production of systemic anti-cancer treatments, or chemo might be a more broader term. And I've also had experience as a clinical pharmacist as well. So that kind of oncology pharmacist is a title that kind of can cover both of those roles. But firstly, I suppose that production role, that role would be normally or more broadly named as an aseptics pharmacist working in an aseptic area. And then there are the clinical pharmacists who undertake clinical verification of prescriptions for those systemic anti-cancer treatments. They undertake medicines optimization, and in some countries, they can do supportive care prescribing or even prescribing of systemic anti-cancer treatments themselves. I suppose that's a broad brush there of the roles. I mean, of course, we do a lot more, but with these roles in some centres, there's a defined distinction between the two. You're either aseptics or you're either a clinical pharmacist. And in other centres, such as ourselves, you kind of get that rotational nature of the job, which requires you to have experience in both areas. So anyway, sorry, that's just to define oncology pharmacists and that. But where does digital health transformation fit into the role? I suppose look at the production point of view firstly, right? There's a huge inherent risk on pharmacists and pharmacy technicians on the production of systemic anti-cancer treatments. These are items which are regularly dose specific to a patient's height, their weight. The doses then could be modified due to hematological side effects, renal, hepatic impairment, or several other kind of side effect reasons. The pharmacy team then, due to the aseptic nature I'm talking about there of production, we're hidden away in a clean room producing these items. So this is where the first impact of digital transformation is seen in communication. So ensuring that a consultant in a clinic can write a prescription digitally, that it can be viewed by the aseptic compounding unit and by the nurses on the oncology ward for the administration. That's your first, I suppose, stepping stone of it. That brings us on to safety and those modifications we talked about. So when a member of the cancer team makes a decision to reduce a dose or to omit it or to stop a patient's treatment altogether, then that needs to be reflected unilaterally across all aspects of that patient's treatment. So, i.e. on the prescription that's written, that needs to be there. The drug that is to be produced, that modification needs to be there, and then the administration for the nurse administering that chemotherapy. If any of those are different, you're introducing an inherent risk into the process there. So like going back to that individual dosing specificity, there's a safety concern in pharmacy that even if all of the details are correct as well, on that administration record, that there's humans involved in the process and human error is bound to occur. So I suppose we've developed a Swiss cheese model over the years, right? Which is, I don't know if you're familiar with the Swiss cheese model. No. So if you imagine Swiss cheese with all the holes in it, the holes are indicative of a mistake or an error going through of something happening. So the Swiss cheese model is that you put as many slices or as many steps or strategies in place and layer them up so that it's unlikely for all of those holes to line up for an error to get through, if that makes sense.
Yeah, I gotcha, yeah.
So we've done that on a manual basis over the years, but technology can bolster that aspect and that Swiss cheese model as well. So I suppose a simple example of that would be using a barcode scanner to scan a label of a drug used in the manufacturing process. So say if you're supposed to be producing cisplatin chemotherapy for a patient and you pick up a vial of carboplatin, then a scan of that label will notify you that you've selected the wrong drug. So that picking error then has been eliminated. Similarly, on the administration of that drug, we can use another barcode scanner to make sure that the drug matches the patient's details and also to prescribe chemotherapy on the treatment plan. And like barcodes have been around for years. That's a very, very simple innovation that can be used, but it just needs to be introduced into the system. And then we can also look at staff safety. The processes currently being undertaken by staff members be partially replaced by robotics. So compounding of chemotherapy is still a very manual process, but the introduction of robotics and automated pumps or systems can input details into the system to help with like this manual process of production. And that can reduce repetitive strain injuries, and it frees up our technicians who are involved in these processes. It allows them to advance their roles in other areas of cancer care, maybe to become more clinically developed. And speaking of clinically, then look at so that was more so about the aseptic process. If you look at the clinical cancer services end of things, not to blow your own trumpet, but that's where I suppose apps like OncoAssist comes into play. Pharmacists, I've always kind of said that we're touted as the clinical researchers on the team. We're the ones who the difficult pharmaceutical questions are asked of, the ones who need to seek information out in protocols and guidance. We're the kind of the reference sources for that. It's not that long ago that we're the ones that had the BNF cable tied to our wrists and being at the better and using that as our main resource. But I suppose that list of resources now that pharmacists utilize is way bigger than just the BNF. We need to easily and accessibly have resources at our patient's bedside or at a team meeting and give those levels of evidence and references. So calculations and formulas for chemotherapy-induced risk factors or VTE prophylaxis risk scoring or other formulas, that I suppose helps us to efficiently assess and optimize treatment for patients. Information and data in healthcare systems is often siloed. We're utilizing several different systems across both digital and paper-based systems to formulate that picture of the patient in front of you. And I suppose just to wrap it up, digital transformation it's easing that access of information and presenting it in an accessible format. That's our current state of affairs that we can kind of get to.
Interesting. And as a lot of the technology you mentioned there, is that implemented in your center as we at the moment, or is it something that's kind of aspirational?
Some of it is, and some of it is aspirational. Like I suppose, so like OncoAssist, that is available. Barcode scanning is being implemented at the moment. So, and like robotics, that's something that's being developed across Ireland. So I can speak about that actually if you want. There's a couple of centres in Ireland whereby that's kind of the future, I suppose.
Yeah, I suppose that leads on to our question, like what you think, like Ireland and globally, the future of future changes in your specialty, I suppose.
Yeah, so I suppose that robotic process there, that's not too far into the future. It's already touching certain cancer centres in Ireland, St. James's and St. Vincent's hospitals in Dublin. They've already progressed with the installation of a fully automated chemotherapy compounding robot.
Very good.
And again, that siloing that I was speaking of there, we want all of these systems to integrate one another. So the integration of this robot in those centres with a national cancer information system. So just to explain, this is Ireland's digital solution to I suppose combining the majority of the aspects around prescribing, discussion, production, and administration of systemic anti-cancer treatments. So I suppose that integration will mean that an item prescribed by an oncologist can be directed by a pharmacist without the need for separate systems onto the compounding robot and prepared at a time that suits. So that's something that's already, I think the integration piece is still needs a little bit of time to come in, but like we're seeing those very what definitely seemed futuristic components of digital health transformation really rocking in at a quick pace, and internationally it's been already been done. I suppose we also then have to look at the efficiencies that can be developed in that automated system. So, keep on growing on this. So are there treatments that can be batch produced and made more efficiently, and how can they be identified? Are there patients who show up at 8 a.m. in the morning of treatment and they're consistently there with acceptable blood levels, and they could be in and out of the door quickly? Is there any way of identifying those patients who are not likely to get into trouble, and I suppose have their treatments ready? Are there patients who would be capable of receiving chemotherapy themselves in a community or at a home setting? And how do we identify those patients? Are there other strategies that we can utilize these systems to, I suppose, help with our capacities constraints and things like that? You can look online at the moment, and you can see in-depth chemotherapy protocols, which they speak about the parameters that a patient has to meet to receive chemotherapy. It also shows us the parameters which a patient needs to be monitored under for the duration of their treatment. So we still need to tie these systems together, like lab values, patient assessments, to make the flow of that patient much better. We still have situations whereby patients are arriving on their day of chemotherapy and telling their stories of side effects and problems from the last 14 or 21 days since their last chemotherapy cycle, and an assessment then being undertaken by the nurse or doctor at that stage as to whether to proceed or not with chemotherapy. There's a lot of data and information that could be taken at a more appropriate stages, like let's say right after a patient has vomited. Like, can that be recorded? Can that be identified, that we have a timestamp? Because then we can know whether that is acute or delayed nausea from the chemotherapy. And that means there's a means of catching it earlier so that the patient doesn't suffer for the remainder of that cycle of chemotherapy or for the rest of the duration of treatment. I believe you guys might be doing some work in that area in the future, and that's a great opportunity, I suppose. I suppose cleaning up of data or capturing data, clean data at the right point, at the right time, is paramount for the ability to utilize these systems in the future, really. Yeah.
Very good.
Excellent. Could you tell us a little bit about the Irish Haematology Oncology Podcast?
Oh, of course, yeah. So I'm glad you asked. I suppose one aspect of digital transformation I haven't spoken about is the development of education digitally. We have the opportunity now, with better access of tools, to develop content for healthcare professionals and patients to better educate them on the cancer they are receiving. The Irish Cancer Society are doing wonderful work at the moment, as well as internationally Macmillan and other things in terms of educating patients. And I've been involved with some videos with the Irish Cancer Society, educating patients kind of on a global scale of how to manage oral anti-cancer meds, or if you have prostate cancer, some of the kind of I suppose tips isn't the right word, but some of the education that's needed for patients there. Education of healthcare professionals, I suppose that's where the Irish Haematology Oncology Podcast comes in. It's an alternative route of educating our healthcare professionals in the fundamentals of chemo care. I've attended many conferences and journal clubs over the years, and there tends to be a high level of baseline understanding needed to appreciate the topics discussed at these meetings. So I suppose my aim for the Irish Haematology Oncology Podcast is to develop an easy means of introducing the core concepts of cancer care and building upon that in a systematic fashion in order to bring people's knowledge up together. The episodes are intentionally concise. developed to be perfect for staff who can listen during their commute or while on a break or catching up with paperwork or things like that. And I started the podcast talking about aspects of core cancer care in terms of safe administration of systemic anti-cancer products. I started with safe handling characteristics, how the drugs work, how to manage or identify infusion reactions, cancer staging, neutropenia, renal impairment, hepatic impairment, side effects, all items that I suppose you typically come across on a chemotherapy protocol or regimen. I wanted to explain these items so staff members could understand the concepts and I suppose to empower them to ask the questions of the care patients were receiving and ensure that the basics of care were covered. I aim to build upon this to specialize people's knowledge and expand it so that this becomes akin to that journal club I've mentioned there, that those speciality developments can be spoken about, but I suppose with that fundamental basis built up to have that underlying knowledge. I suppose it'll be probably a bit akin to the Harry Potter books in terms that it'll grow in complexity along with you, you know.
Very good. Very good.
I suppose, what was the inspiration behind it? I know obviously just bringing knowledge, but what inspired you to actually start the podcast itself?
I suppose the inspiration of it boils down to COVID and the unexpected consequences of it. We had Oncology and Haematology Day Ward move offsite from our hospital to another private hospital facility. So now not only did we have our segregation of staff who were working in the clean room, but we also had a huge cohort of nursing staff who were in a separate hospital 20 minutes drive away. So the lack of a shared education experience there for both of us and for them, then it became obvious. We could update a protocol or policy. So, for example, a recent one was our cisplatin hydration policy. So that education piece there for the nursing staff would entail of someone having to drive over to the day ward and deliver that education session to the nurses who were present that day. And you can even see here that you're already missing out on the cohort of nurses who are rostered out that day. Yeah. So, and that's the case for every department, whether they're on site or not. So I initially started developing some video content then for educating staff members, and video content it's important for some aspects, like showcasing what a new prescription template or something might look like, or if there's a process-driven aspect to care, you can kind of showcase step-by-step video footage. However, it's very time-consuming process to create video. We also had a large turnover of staff at the time as well, especially in the nursing department, and it was due to a large number of alternative nursing opportunities for promotion and stuff were offered, and a large cohort of very experienced staff, they were gone in one fell swoop. And we had a rolling employment campaign underway. So instead of trying to catch them at every individual induction and educate them, I suppose I had the idea of developing something which could be quickly develop those fundamentals and be accessible for them in their own time. In the podcast, I often point towards a guideline, which I'm referencing the podcast about. So neutropenia, there's, an ESMO guidance document on neutropenia. So now I suppose this can now be your visual aspect if you want to learn along with the podcast, or maybe your hospital has its own policy that might differ slightly from what I'm saying, but again, it's in line with the overall concepts. So I suppose that's why I thought that the podcast was an ideal format for delivering this form of education. And if it was video or another format, I wouldn't have the time to do it.
Of course. I will be sure to link it below in our own podcasts, so everyone can access to.
And just thinking about some of the challenges facing oncology professionals today, what do you see as the biggest challenges that they have?
I suppose that kind of ties in with your question on why I specialize in cancer care, and I suppose that is the progressive yet challenging nature of the job. It showcases how much more innovation is coming down the line and how you need to stay on top of all of that information. The therapies that are being developed every year, like they're becoming more and more targeted, and newer targets are being developed every year as well. So what do you do? How do you stay on top of everything? How do you have a patient sitting in front of you in clinic and you take into consideration all aspects of that patient's health profile and convert that to a full treatment plan for that patient, whether that be chemotherapy, surgery, or radiation, or a combination, and ensuring that you're not only conforming with the best gold standard practice, but also that you give consideration to the legal aspects of what the drug is licensed, maybe, or if that drug is reimbursable, and if it's cost efficient for the state. There's a lot of, I suppose, considerations that need to be considered. It's a minefield of information that oncology and hematology professionals have to deal with, and oftentimes it's across a broad media of information sources. On one hand, it's exciting to witness the rapid progress that's been made in cancer research and treatment, but on the other hand, it can be overwhelming to keep up to date with those kind of latest findings and incorporate them into our daily practice. So I suppose that's where digital tools can play a crucial role in streamlining information or facilitating collaboration and ultimately improving that kind of patient care.
Very good.
Yeah. And how can tools help address these challenges, do you think?
A lifeline for oncology professionals. As I said, there's a lot of complexities in modern cancer care to navigate. In Ireland, I suppose we're seeing that surge in the adoption of a national cancer information system. I suppose these systems can analyze patient data, recommend treatment options, and even flag potential drug interactions or contraindications, all in a matter of seconds. Patient portals, they're another powerful tool. They can empower patients to take a more active role in their care. They could access, medical records, view test results, communicate with their healthcare team, and even appointments. That's a huge issue as well at the moment. Capacity challenges for us as well. And we're all able to book our barbers and book our gym slots and stuff now, but scheduling appointments oftentimes is still a very manual Excel-based task to do. So that scheduling of appointments as well, and allowing patients to slot in, obviously in line with their treatment, but giving them a bit of ownership over that as well. So that not only improves patient engagement and their own empowerment of their cancer journey, but it frees up valuable time for nursing staff and clinicians as well. And I suppose telemedicine as well. That's making a significant impact, particularly in rural areas where you don't have to travel an hour and a half, 2 hours to your hospital to undertake a consultation or to go to a clinic. Patients can receive their care from the comfort of their home, and it's a great service that's on offer. Yeah.
Excellent. Do you see any opportunities for AI in oncology?
Yeah, definitely. Yeah. All of this data, and potentially, if it's all digitized and that digital transformation does occur, we have all this data and we have it collated. So it can be trained to make consistently similar decisions to expert oncologists when presented with the same cohort of data. So can we pool all of the health data associated with a patient, reference that against maybe treatment protocols and supportive care guidance? So train it to have the reference documents. Like oncology and hematology is very protocol driven and clinical trial data driven. Can we train the system to use those as your references and deliver the recommendations then with all of that patient's health data to the consultant oncologist or hematologist as to how to proceed with a treatment plan. And then that's to be reviewed then by your oncologist or hematologist. And I suppose if that's accepted, then you can develop that entire treatment plan for the patient. So when do bloods need to be booked in for? When do scans need to be booked in for the patient? And using that booking system, which matches the needs of the patient and the service, and taking into that capacity issues of the system. I suppose it's just making the systems that we have in place already, showcasing that and presenting that to the oncologist or hematologist in a very accessible way.
But it's kind of like you have a specific patient with a specific type of cancer and a specific mutation, just making sure there's consistency, is it, around the
exactly. And like not only that, but like so that's one aspect, that you have your markers and your specifics about your staging of your cancer as well, but also looking at other factors, if patient has other healthcare comorbidities, their age, their frailty, the bloods that they've received, if they have renal or hepatic impairment, and maybe tailoring the treatment based on guidance that's already out there, directing people what to do in these cases. But it's allowing a huge health data set. If you think about a patient and all of the different scans or bloods or everything that could be related to them, the medication they're on and everything, and giving all of that as a guidance and an overarching recommendation as to what to do. Maybe you don't start off with your 100% dosing for a patient. Maybe you actually go in and you give them at 80% because they're going to be, they won't tolerate the 100% just from that. And that's the decisions that already have to be done by oncologists and hematologists. But it's a lot of work, and getting that all right is difficult. And I think AI can help to just pool all of that health data together and assess it and give those recommendations.
Very good.
Interesting. Yeah. Does it all sit in different systems at present? Is it all kind of like
in terms of like your scans and your and everything?
Exactly.
In Ireland, yes, that National Cancer Information System that I'm speaking about there, it is aiming to tie a lot of those systems in together, so that your multidisciplinary team meetings, that cancer staging and blood results and things like that are going to be tied into the system. But I suppose systems are only as good as the parameters that you can input into them. And if some things are missing, then you can't input it. And then I suppose there's no AI involved in that system as well. So that's holding all of the data at the moment. But to recommend or to assess that data.
Very good. And finally, just looking ahead, what are your goals and aspirations in advanced cancer care, both within your current role and through broader initiatives like your podcast?
Thanks. Yeah, I suppose I hopefully have made it evident enough that I have a passion for digital transformation, and that's where my goals lie. I suppose I want to make cancer care as easily accessible for both patients and healthcare staff alike.
Yep.
In my current role as chief pharmacist or a pharmacy services manager in a cancer centre, I can try and impact local changes as best as I can, and try and develop efficiencies in our system and keep advocating for the advancement and adoption of technology to bolster the advantages, I suppose, that we've spoken about throughout this entire podcast. On a broader scope, I suppose you also need to empower those changes nationally and ensure that all hospitals are developing at the same rate, and that we're not disadvantaging hospitals or care depending on executive structures that are in the hospital. So that's, I suppose, that the example there of that National Cancer Information System that came in, that was developed from the National Cancer Control Programme, and it was sent out and implemented in all 26 public hospitals who are delivering cancer care in Ireland. So that accessibility is paramount to the success and the adoption of these technologies, that you need that kind of national reach, and you kind of need to keep knocking on that door to ensure that people are aware of it. Onto the podcast, I suppose I want to keep the education of healthcare staff and patients as easily as possible, and allow people to access education in a format that is accessible to their own lives and structures. For the next progression of the podcast, I suppose I'd like a little call to action here, and that's to develop a series on the fundamentals of each cancer disease types that there are. So the podcasts that I've created so far have been, I suppose, very pharmaceutically heavy, involving protocols or policies generally involving medication, and protocols and policies that I've normally had a hand in developing on a local level, let's say. I'm comfortable talking about those items, anything involving medication and those. I'm comfortable in talking about those. Cancer disease types, however, that'll go into diagnosis, staging, and treatment strategies for cancer disease types, such as, like, let's say, for example, early breast cancer. As much as I could probably waffle on about it, it's not my area. Diagnostics and stuff is not my area of expertise, and I want physicians and consultants, oncologists and hematologists who are involved in cancer care. It doesn't even have to be consultant oncologists, and there's many specialist registrars and stuff who are well equipped to do it. And I want them to come on and talk to me as if we were having a coffee together, and explain those kind of fundamental concepts of those cancer types. And I suppose I want the podcast to develop beyond me, to become I suppose, the alternative journal club for hematology and oncology care. And for people with research or topics that they want to promote to come on and celebrate their achievements in a simple, jargon-free way. Oftentimes with the production of articles and abstracts for submission to journals, there's a very specific way in which you have to talk, and it can be jargon full, really, way, and quite complex in doing it. And there's obviously a lot of things that need to be mentioned in an article, but can you come on and explain that to me in a nice and simple way? And that's what I think what people want to hear. So I suppose if you do want to come on with me, you can drop me an email on the Irish Haemonc Podcast at gmail.com, or you can drop a message to me. I have an Instagram, Irish Haemonc Pod, and I'd be more than delighted to get you on board.
Brilliant. Sounds good. Thanks very much, Owen. Really appreciate it. And
thanks very much, Owen.
Your work is really good. We really appreciate the podcast as well. So thanks very much for setting that up and making it available to everyone globally.
Yeah, no problem, and thanks to you guys as well. It needs to be said that accessibility of your app is so key to the delivery of, not easy cancer care, but making things a lot easier for people to be able to research something at a patient's bedside or in a meeting, or to get those formulas there and then, that you're not scrolling through several tabs on Google or whatever. It's great, and I do commend you guys for that as well.
Thanks very much.
Thank you. Thanks.